Poirier. I'm a registered nurse taking the course Breastfeeding Experience through BCIT. Welcome everyone to my presentation about mothers with sore or flat nipples with babies who have jaundice. I will be using the clinical decision-making process focused on the breastfeeding challenge to go through this presentation. The framework helps create a care plan for a mother who has sore or flat nipples and a baby who has jaundice. This involves development of knowledge in specific areas, cues to guide reflection, and judgment on decision-making process and outcome. Let's start off looking at the condition jaundice. What is jaundice? Jaundice is the condition that causes yellowing of the skin and mucous membranes, most notably in the sclera of the eyes. The yellow pigmentation is due to the excessive bilirubin that the baby's body cannot get rid of through feces or urine. What is bilirubin? Bilirubin is the product of red blood cells breaking down. The bilirubin remains in the bloodstream, causing the yellow pigmentation. It starts at the top of the infant's head in mucous membranes, goes down to the core of the infant's body, and then to the extremities. What are the different types of jaundice? There is pathological, physiological, and breast milk jaundice. Pathological jaundice, or liver disease, occurs within the first 24 hours of birth, and it is not a normal pattern of jaundice, most likely caused by conditions that increase the rate of red blood cells breaking down, such as blood group type, Rh incompatibility, RBC defects, hematomas, infection, or hemolytic diseases. Physiological jaundice, also known as starvation jaundice, occurs after the first 24 hours of birth. It's a normal increase of bilirubin in infants who are coming from an in utero to a high oxygenated environment, usually due to the increased load of bilirubin from increased volume of red blood cells, immaturity of liver at birth, or decreased uptake of bilirubin from the plasma by the liver. Breast milk jaundice, there are two different types, early and late onset of breast milk jaundice. Early onset usually occurs in the second or fourth day of life. It is thought that the cause may be from infrequent or ineffective feedings that decrease the passage of meconium. Late onset usually occurs in the fourth or sixth day of life and peaks around the second week. It is thought to be a substance in the human milk that inhibits the conjugation of the bilirubin, a factor that isn't in colostrum but more in mature milk. It is important to educate all mothers on the signs and symptoms of a baby having jaundice. Here are some cues. Look at the coloration of the skin. The bilirubin leaves the vascular system and permeates other vascular tissues, starting with the skin, head, sclera, and other mucous membranes down the trunk to the extremities. Assess every newborn in natural daylight. You can also assess by putting pressure with a finger on a bony area, such as the forehead, for a few seconds while the capillary is empty. And if the blanched area looks yellow, it may be an indicator that the infant has jaundice. Assess the infant's behavior. If the infant becomes increasingly sleepy, unable to stay awake for feeds, or isn't eating about 8 times in the first 24 hours, the infant may have increasing bilirubin levels. You may notice that the infant is also cranky or irritable. Check the infant's output. How many diapers did the baby have today? Wet and dirty diapers should be counted. Babies have about 1 wet diaper at day 1, 2 wet diapers day 2, increasing to about 6 wet diapers per day, whereas the baby may have 1 dirty diaper every day for the first 3 days, then adding 1 each day, increasing to about 3 to 4 diapers per day. The infant should also be weighed. If the baby's weight drastically decreases, it may mean that the baby is not getting an adequate supply of breast milk. Checking lab results while you're in the hospital will help guide clinicians on treatment. Serum bilirubin levels are taken from the infant and measured at the lab. The Billy tool can be used as an hour-specific nomogram to indicate to the clinician if the infant is low, medium, or high risk of hyperbilirubinemia. Next, let's look at an overall assessment of the infant for cues of jaundice. The trend of serum bilirubin levels are important to look at, as well as gestational age, age since birth, time of onset of yellowing appearance, family history, infant's output, maternal Rh factor, feeding method, evidence of hemolysis, and infant's physiological status. the severity of the serum bilirubin levels the infant may need, increasing the frequency and amount of feeds. It's important for the clinician to watch the feeds so they can be assured that the baby is receiving colostrum or milk. If the infant is receiving colostrum, which has an laxative effect, the baby will be able to pass meconium easier, therefore helping excrete the bilirubin out of the body. More skin-to-skin contact is always beneficial for both mom and babe. It may also need added supplementation of expressed breast milk, so teaching mom how to hand express and pump is preferred. Phototherapy may also be required. They are fluorescent lights that are directed at baby's skin. Then the light is absorbed and the bilirubin is formed into a product that is easier for the infant to excrete in stool or urine. Phototherapy is usually done in the hospital in an incubator, but can also be done with a specialty phototherapy blanket and can also be done at home depending on the availability. If the serum bilirubin levels aren't trending down, the infant may need to see a specialist to get further testing. There are certain challenges that can occur with feeding a baby with jaundice. Factors that can affect feeding are sore or flat nipples, which could affect the ease of the first few latches, then lead to difficulty of latching later on to the breast, which could cause less or infrequent feeds that don't fully remove the milk, therefore reducing the milk supply, creating a negative cycle. Nipples come in all different shapes and sizes. Usually the appearance of the nipple doesn't have any effect on the function for feeding. However, if the nipple doesn't invert or stretch, the breastfeeding may be more difficult to establish and the ability to transfer milk may also be affected. Ideally, the infant suckling on the breast with such force will draw out the nipple between the hard and soft palate so the infant can get the reflex to suck. If that doesn't work, using an electric pump may draw out the nipple. If the latches are poor and the infant cannot draw out the nipple, it can cause nipple abrasion, damage, or pain, or making it even difficult for the infant to meet its dietary needs. It can also cause mom a lot of negative emotions such as stress, frustration, or feeling like she wants to give up. What we need to focus on with mom and babe is prioritizing this breastfeeding challenge. We need to encourage mom to exclusively breastfeed the infant. It's important to tell mom the size of the infant's stomach so she doesn't feel the baby isn't receiving enough. Start feeding early within the first hour of life, and as often as possible with a minimum of 8 times in 24 hours. Help mom and babe establish a proper latch and positioning and teach mom what baby's hungry cues are. As well, explain what effective feeds are and what proper transfer of milk looks like. Getting moms involved in preventative treatment can help prolong breastfeeding. Start off supporting mom in her decision to breastfeed. Demonstrate how to get a proper latch and how to position the baby. Reiterate the importance of the 3 key priorities we are working on. Get mom to start hand expressing within the first hour of life. It is ideal to get the milk moving so we can increase the milk supply and if need be, use it for supplementation. Nipple stimulation by manually rolling the nipples or a breast bump can also help draw out the nipple. Explain to mom the use of colostrum or lanolin and help irritated nipples, and possibly using a nipple shield to help draw out the nipples so the infant can latch on properly. However, the nipple shield should be taken off as soon as the infant is able to latch well. And last but not least, possibly going to a lactation consultant if needed. At the end of your time with mom and babe, it is important to evaluate mom's understanding and see how she feels. Did she find the information helpful? We can give her written or visual resources so when she goes home she can look at it. Make sure if she or baby needs any consultations or further testing that they are organized before she leaves to go home. Thank you so much for watching. Hope you enjoyed it. Here are some quiz questions to test your knowledge.